that we have Dr. Elisabeth Cannata with us today, a fellow psychologist, long-standing psychologist despite her youth, here in the state of Connecticut. And Elisabeth knows really so much about the landscape of children's services and needs here in Connecticut. So just a wonderful, wonderful resource. And has lots to share with us. And what Elisabeth was saying to me a few moments ago was that she's happy to go in any direction we want. There's some things she will present to us, but she can field questions or present more depending on what you all would like for her to do. She has been just so creative, so innovative. We still have lots of challenges, there's no doubt about it, with behavioral health care for children and families as well as adults here in Connecticut. But Elisabeth has worked to address many of the issues in various ways. So, and really appreciate all that she has done for Connecticut's children and families over all these years. Elisabeth, I don't know if there's more that you want to share. She is has an administrative type position over at Wheeler Clinic for many decades now, right? It's been a long time.
28 years.
How many years?
28 years, 5 days and 20 minutes, something, at least 28 years. September 5th was 28 years.
Oh my goodness. Oh my goodness. And you have here folks who are in numerous different types of settings. So from private practice, Yale, school, psych, neuro, psych kinds of consulting, evaluating, and you name it. We have folks in different stages in careers too. Katie is over at CHDI. So anyway, and good. We got a good mixture of folks. So all different kinds of settings.
All right.
Anyway, so I will turn this over to you if there's anything else you want to tell folks about yourself.
Okay. All right. Well, so thank you. And yeah, my day job is working at Wheeler. I'm vice president of community-based family services and practice innovation. I've been at Wheeler for 28 years, really working across our system. When I started working there were about 300 employees, and I was responsible for our clinical services in the school and our children's outpatient services. And then over the years have moved into different roles, overseeing different types of programs. I do a lot of program development and oversee community-based programs, a lot of our evidence-based in-home family treatments to strengthen families, keep kids in their homes, in the community, keep kids out of more deep juvenile justice involvement. I oversee a lot of protective service types of programs where families are referred because of abuse and neglect concerns, but where there's an emphasis on strengthening families. I've done a lot with our integrated healthcare development. That's how Barbara and I first started working together, as our first co-located pediatric primary care co-location project. And then Wheeler now has 5 federally qualified health centers where we do whole lifespan healthcare from infancy, through life, but integrating primary care, behavioral health, dentist, nutrition, etc. In that role of all of this kind, before going to Wheeler, I was at Newington Children's Hospital, and I was the senior psychologist on the inpatient child psychiatry unit there. So that's sort of where my career started. After graduate school, I went to UConn. I did a lot of family-based work in different agencies in Connecticut and Massachusetts before going to Newington Children's Hospital, and then I've been at Wheeler for 28 years. In my role at Wheeler, where I do a lot of different kinds of programs, I've become, sort of a system voice. So I currently am one of the tri-chairs of the Connecticut Children's Behavioral Health Plan Implementation Advisory Board. You can see all my titles have all these tongue twisters with them. The Connecticut Children's Behavioral Health Plan Implementation Advisory Board is the legislatively appointed body that's responsible for overseeing the progress we're making on the Connecticut Children's Behavioral Health Plan. And I'm going to show you websites. You can go and find out all sorts of other stuff about this. But after the tragedy at Sandy Hook, there was really an emphasis legislatively pushed to look at the children's behavioral health system, what was working, what wasn't working, what did we need to do, better and differently. And there were a lot of CHDI actually headed up with Yale, headed up this project to get stakeholder input about the behavioral health system at that time. A lot of family voice, provider voice, different stakeholders developed then the children's behavioral health plan based on that feedback. And then this advisory board with all of the state agencies that are appointed that have some role with children's behavioral health. And we see that as very broadly. So the Department of Children and Families in Connecticut is legislatively responsible for children's behavioral health at the public system level. But of course, Juvenile Justice, Court Support Services Division, the Office of Early Childhood, the Department of Social Services, DEMAS. I mean, there's a lot of Department of Corrections. Really, if you think about children's behavioral health, it's tied into family well-being. And so all of these state agencies are appointed to the Children's Behavioral Health Plan Implementation Advisory Board. The project that I'm going to spend most of the talking about today is based on phenomenal system development that's happened in Connecticut over the past 20 years that when I go other places, Connecticut is really envied for the service array that we have, and that I'm going to talk about. And the challenge is, as we've developed our service system, and this is before the challenges we're facing currently, where we have a shortage of staff at every level of our system of care. But when we have our position staff, we've got a lot of treatment options for children and families, and particularly for children and families who are really struggling and at risk of higher system involvement. And so we're kind of envied for the service array that we have. And it's called the alphabet soup because we have all these evidence-based in-home treatments, MST, MDFT, ICAPS, MDFT, PSB, FFT, a lot of different alphabet acronyms to keep track of. And so part of the challenge was, how do you make sure that you get the right children to the right, or the families to the right services? And so the project that I'm going to talk about is the assisted intervention matching tool, which I was sort of in this role of working across the system in different levels of care, have some expertise about the different evidence-based in-home models. So I'm going to talk about that. I want to leave time because if you have, bigger questions, as somebody who is a psychologist and also is involved in all of these systems initiatives, I'm happy to talk about that. But the AIM tool is something that is really intended to help facilitate the connection of children to the services that are best matched to their clinical needs. So before I switch to my PowerPoint, does that sound, Barbara, like the plan? Is there anything that anybody else that you came here hoping that I would talk about, so that I make sure I can lean it in that way? But once I start screen sharing, I won't see all of you. So that's why I'm asking before I start screen sharing.
I'll appreciate you asking. I think we can start there. Certainly if something comes up that strikes you, just write a question in the chat, or don't hesitate to just, say, and we'll leave time. I really appreciate you being flexible like this too. And that's what we want to do, is address whatever questions you all have. So let's start with the AIM tool, and then we'll go from there.
So shout out, because I won't see you, and Barbara, maybe you can check, monitor the chat.
Yeah.
All right. So. No, wait a second. Are you seeing, and is it on the screen in a way that you can see? Are you seeing getting youth matched to the right treatment? Oh, I've got the wrong.
Yeah.
Hold on.
No, it's perfect. Yeah.
All right. It says presenter name, so you know who I am. And I just want to mention that the AIM tool was funded by federal funding to the Department of Children and Families, first through funding through SAMHSA for adolescent substance use treatment, and more recently through the Connecting to Care grant that Connecticut has had for many years and was recently renewed. And as I was saying, the Connecticut system of children's behavioral health services is quite complex. We have multiple levels of care, both at a clinic and office-based level, as well as in-home kind of service delivery mode. And we have many models of intervention that are research supported. And because Connecticut has really invested in the infrastructure to provide ongoing quality assurance, it's not enough to say, oh, we're going to do such and such a model, and you train everybody once and then you expect them to go on doing it. Connecticut, as they've implemented different models at the statewide level, have invested in maintaining ongoing quality assurance, fidelity monitoring, ongoing training capacity, either through centers of excellence like CHDI overseeing outpatient evidence-based interventions, to working with the model developers to make sure that we have the infrastructure to sustain the rigorous implementation of evidence-based models. And because Connecticut has been very serious about that, we're frequently chosen by researchers and model developers to partner in studying adaptations of models to extend the research and science, if you will, to populations that may have been underserved in the past, but where we have models that might make sense with adaptation to be extended to the service continuum. But all of that leads to complexity when you're looking to make a referral. And for those of you who are in private practice, this would be families that you're working with where the child's level of distress may be, or the family distress is elevated and beyond the level of support that you might be able to provide in an outpatient context. Or you're working with families that have complex needs and multiple system involvement. Making sense of the alphabet soup of evidence-based practices and in-home interventions can be complicated. So the original development of the AIM tool, Assisted Intervention Matching Tool, actually started as a very small project. The Department of Children and Families asked me to work with them to develop a decision tree on paper for DCF workers to figure out which model of the service array that they had of in-home interventions should they be referring kids to, and understand those decision-making points of referral consideration. Because as the system that's involved, DCF being responsible for children's behavioral health, they have many programs that are available to children in the community. They do not require DCF involvement. And then there are other in-home interventions that are more designed on protective service types of concerns where you do have to be DCF involved to get connected. Those are often focused on the parent as the primary reason for coming into treatment. So the idea was I would help with this decision tree for in-home services that DCF was funding. And as we were doing it, somebody on the work group said, what if we had like a web-based platform and DCF workers could go in and they could like answer questions and they would land on what the right intervention was. Like, oh yeah, that would be cool, think technologically. And so that was what really started it. And of course, once we started to develop this tool, it was clear that we would want this not just for DCF workers, but for providers to know which in-home service. And if we're going to have this for providers, why wouldn't we want it for families? And so that is really how this all started. So the AIM tool was launched probably about a year, maybe a year and a half ago, for the in-home service array, and it was available on the Connecting to Care website. And there's a version that's for DCF workers, a version for providers, and a version for parents. Really, the provider and the parent version, the DCF and the provider version are pretty much the same. And again, this was only for in-home services. They ask questions whether you're looking for an in-home service because you're concerned about the parent maybe placing the children, there's some parent intervention need that puts the family at risk. And that could be just the need for getting wraparound kinds of supports and access to, basic needs and some of the social determinants of health. Or it could be that maybe the parent is struggling with their own substance use. There has been substantiated abuse and neglect. Substance use is part of that picture, but if we could provide intervention in the home, really enhancing safety, enhancing treatment, we could strengthen families and keep them together rather than separating children. If you're familiar, and I can talk about this at the end, the federal legislation in 2018, the Families First Prevention Services Act, prior to 2018, states were reimbursed for placing children in foster care. States weren't reimbursed for placing children in foster care. States were reimbursed for the costs of foster care. So when children were removed and placed in foster care, the states can capture reimbursement from the federal government through Title IV-E payment mechanisms. The Families First Prevention Services Act changed the way that states would be reimbursed, with the idea that children who have the best outcomes are raised in healthy families. Clearly, we know this. Children who, the next best is, rather than being removed from the home, if you can stay with your family, that's better in the long-term outcomes for children. If you can be kept in your home safely. If you can't be kept in your home, then being placed with relatives would be the next best thing, or people that you know. And if that can't happen, being placed in foster care, but hopefully with a long-term plan and a permanency plan. So now states will get reimbursed, instead of for children in foster care, they would be getting reimbursed for models that strengthen families and keep families together. And so Connecticut was involved in a very comprehensive process to identify what in-home interventions, because that was really the emphasis of Families First legislation, is that you needed to use evidence-based practices to strengthen families. We already have a whole ton of this in Connecticut, but the reason I'm emphasizing that here is that this notion of providing in-home services, treatment-oriented to strengthen families, is really something Connecticut was doing for a long time, that this tool would be intended to help match families to the right service. But for the family version, the focus is not on is only on if the child is the one in need of behavioral health services. In the provider, in the DCF version, you could have a parent who is the primary focus of in-home intervention. Because this took off and was really helpful, and people of different perspectives, DCF workers, providers, and families, found it helpful, the question really became, but how do you know you need in-home services, and what if you need something that's clinic-based? And so now the AIM tool that will be launched on Monday is for the continuum of children's behavioral health services, clinic and office-based, home-based, everything except out-of-home care. So it goes up to partial hospital level of care, but not inpatient and not residential level of care. So what the AIM tool is intended to do is help to guide the user to ask questions that help them to narrow in on what type of intervention do they need that might be available broadly in Connecticut. It is not intended to be a diagnostic tool, although it asks questions that try to narrow in on the clinical presentation. And it's not intended to replace consultation with outpatient providers if you're working with outpatient providers, or with the regional resource group at DCF that provides mental health consultation, or if you're working with other systems, you would still want to work with them. But this can help those people working with you, and it can help a family be informed about what might be some resources that they want to pull in. And the goal is to provide information that can narrow in, but also tell you where you can get those services if you find something that you're interested in. And it helps to identify resources for some of the populations that are typically excluded from many treatment programs. Where there's something available, we've tried to at least hone in on where you can get additional information. The goal, and what we thought about, is by helping the user to guide them through the kinds of questions you need to ask to match people to the right treatment, that we're actually training the workforce to be thinking about what is it that you want to ask a family, so that you can refer them to a service that's well matched to their intervention needs. Because what we know is, for all of evidence-based treatment, it's only as good as you get the people in the door that model is well designed to treat. So this is what it currently looks like, and I'm going to step out of this presentation, because as of Monday it will no longer look this way. But I can't bring you to the new website because it's not live, and I've been instructed not to mess it up so that it can be launched on Monday. So I'm going to stop sharing for a moment, and then I'm going to bring you into the tool. The assisted intervention matching logo will be the same, but the screen is going to look a little bit different. And so I'm going to now share that with you. So if you go to connectingtocarect.org, and you'll see that on the next slide, or on the next screen when I get there, you will, as of Monday, you will be able to get to the expanded AIM tool. If you go there today, you'll get to the in-home version of it. And they're redoing the website, so it's going to look different. Okay, I can't talk and connect and link at the same time, so let me pause for a moment so I can get you to the way the tool looks. All right, let's see if I can, I'm having trouble. I don't use Zoom daily and here it is. Okay. So are you seeing a blue screen with a father and son?
Yes. Yep.
Okay. So on the new, what I can't see is the top of it, but you can see at the top, are you seeing my arrow move also at the top of the screen, like in the field that would be where you'd be typing in a web address? I'm moving my arrow, my cursor. Are you seeing that move, Barbara?
I see the arrow. I don't see it moving right now. I don't know if
All
you're
right.
moving.
So what I wanted to draw your attention to is connecting to care, connecting. Yeah, this is not, so don't look at the web address there. I will type it in the chat when I finish presenting. Connecting to carect.org is where you would go for this. I will make sure that you have that. Then you will see at the top of the screen, it says programs and services. You can click on that. You'll see AIM tool. And once you get to the AIM tool, get started, it brings you to who are you. And the point here is whether you're DCF worker, provider, or other, you will go to the same tree. If you said parent or caregiver, you will go only to how old is your child is like the next question. So let's, for the sake of this, since you're all providers, let's assume that you're going there as a provider. So are you seeing the whole screen? Is it legible? I can't tell what you're seeing.
Yeah, we're seeing number one, focus, and then there's parent focus, child focus. You have to scroll down.
Okay, but you can see the whole screen, right?
Well, we don't see like we see age of child.
No, I mean like the left to right. Are you seeing?
Oh, yeah.
Okay.
Yes.
Yeah.
Yeah.
So what's beautiful about this tool is you can go back and forth. If you click on something, you say, oh, that's not what I want, you can unclick and you go right back to where you were before. So the first question is, are you focused on parent as the identified intervention need is going to be for the parent because you have some concerns? Again, this is not intended to be the whole behavioral health system for adults. It's intended where you're working with families, you're concerned about child well-being, but you're concerned about the child well-being. It really has more to do with, we need to connect this parent to resources, or this parent needs treatment for concerns like parenting intervention, not as much focused on the child as it is focused on the parent's needs. And then there's the child focused version. So for the sake of this, let's really focus on the child focused version. Treatment options to address child adolescent behavioral health needs. And we wanted to make sure that everybody was clear when we're talking about behavioral health. We mean, you all know this, but that is not common knowledge necessarily in the public. What is behavioral health? Includes both substance use and mental health and co-occurring. So then the next question is the age of the child. And right now, if you click on birth to 5 or 18 to 22, birth to 5, you're going to be referred, I'll show you because it is easy to go back and forth. You're going to be referred to the Office of Early Childhood website, which has also recently been renewed and updated, and it will tell you, and if you click, I'm not going to for the sake of not taking us off track, but if you click on any of these, it'll take you right to the place on the website that would get you to programs and services. But we wanted to have more distinction, even in the early childhood range. Really, what is it that you're looking for? So do you have concerns about your child? You don't think that, they're on track developmentally, but there's never been an assessment. That's going to be one set of services. Or my child already has been diagnosed with some developmental concerns and I need some services to address that.
This meeting is being recorded.
The goal is that there's going to be some discrimination about which of the many services in the Office of Early Childhood are best suited. But that is being developed. I'm working with the Office of Early Childhood to get that decision tree sorted out. So I'm going to click back. The 18 to 22, we at first we were going to include specialized services and decision tree for the 18 to 22 because we were aware that many parents would come here concerned about their young adult who, technically is eligible for the adult. I mean, that's the thing. If you're 18, you're eligible for the adult service system. And yet we know that this age population, 18 to 25, have some unique needs that are not just that they're adults and they can use the adult system, that there are developmental transition age youth, emerging adults. There are particular needs that they may have. But we realized that this tool really couldn't do justice to that. So if you click the 18 to 22, it says this tool is really intended for the Children's Behavioral Health Service System, But here's a link to a page that we've created an inventory of programming that may uniquely match the young adult population. So it may say things like, if your child's in college, consider the counseling center at your your child's school, college or university. But there are also programs in adult services. Will provide consultation if you've had, significant behavioral health concerns as a child. Maybe you have had system involvement. There are programs that are uniquely designed, IOP programming, dual diagnosis programming, where they understand that they're working with a young adult population. We've tried to inventory resources that we're aware of that are relatively widely available. The target of this tool is going to be birth to 5, but right now it's the 5 to 18-year-old. So it starts to then begin to ask questions to narrow it down. So do you have a behavioral health concern? I mean, if the child's in immediate crisis, then we don't want them using the tool. We want them to get services through 211 or 988 if there's an immediate danger. Is there really need for care coordination? It's not that they need a connection to treatment, but they need help navigating the system. They know what they need, but they can't get it. Then that might be an area we go down. Is it mostly emotional behavioral? There's a new initiative in Connecticut to address racial trauma through an evidence-based model that is designed to work with children who are experiencing symptoms of trauma tied into experiences of prejudice, racism. Is it primary substance use? Is it dual diagnosis? We realized this tool was a great opportunity to help to detect first episode psychosis and get kids directed to the right resource for that. So if there are unusual thoughts, and again, we tried not to use jargon, not to be insulting to mental health professionals, but to help them use language that would be more family friendly. So rather than saying psychotic thinking, we, unusual thoughts, and describe what this is. Is there an eating disorder? Is there autism? And we know that autism is exclusionary for many treatment programs. So that is often an area that's identified children with autism who are struggling in their, maybe they're not so much specifically tied into their diagnosis of autism, but they're struggling with dysregulation at a point in time. Maybe something's happening, there's a change in the family, or they're showing signs of increasing mental health distress. Many of our programs would have, that would be an exclusionary criteria. So we've tried to connect to resources, either home-based or office-based. And again, it's not an exhaustive inventory, but if you click on that, then it would be, does the child currently have a diagnosis? If not, then how can we get a family connected to assessment? If they do have a diagnosis, then what's the level of concern? Because we do have some programming at for children who need a PHP or a hospital-based level at the hospital for special care. So there are different resources that you can connect depending on, special needs. For the purpose of the biggest category being emotional, behavioral, and substance use, or the combination of both, if you click on that, now we get to level of concern. So mild, moderate, or severe. If you click on mild, we're talking about an outpatient level of care. And here too, we couldn't possibly identify every private practitioner, so the intention here is to get to categories and clusters and ways that you can connect to service. So the psychiatric clinics for children are the licensed by the Department of Children and Families, and they have, they do a lot of work with CHDI. Since I saw somebody from CHDI is here, this is the trauma focused CBT, and the match programming is quality assurance through CHDI. So the psychiatric clinics for children, if you clicked that, you would see an updated inventory of where those clinics are, how you can access them, what regions they serve, what the target population is. So you get that information. And what's beautiful about this tool is that you can go back and forth, although when you're in Zoom, you may not be able to do that as easily as when you're on your own screen, not presenting to people. So I'm having trouble closing this out because I can't see my toolbar. Okay, so school-based health centers, you'd be brought to the web of the school-based health centers, and you could type in your town to see if there is a school-based health center. For private youth service bureaus, some towns have behavioral health services, some don't. So if you go, you'll go to the youth service bureau page, but you'll be right on the linking to services, and you can see whether that's a resource in your town. We also, 211 is an option to find providers, and then call the back of their insurance card. That would be the way they could get to, a private provider. If they have, and this is where I think it's going to be most interesting to those of you on the call who might be looking to use this tool to connect families to higher levels of care. If you were describing moderate, is the child currently receiving treatment? If the answer is yes, then talk to your current provider, maybe an IOP level or an extended day level, or functional family therapy, which is an in-home based treatment. And again, you can click on any of these and you'll be brought to the listing of providers. If you said they are not receiving treatment, then you need to get outpatient care before you're going to get a more intensive level of care. So again, you go to the outpatient level, and then that might help connect you. But let's say you have, this is a child who's really at risk of repeated hospitalization, out of home placement, more serious involvement with juvenile justice, or they're risking school failure, high level of emotional behavioral dysregulation. It brings you to questions. Somebody else has.
One sec, Bob, can you mute yourself?
I'm so sorry. I thought I was muted.
You were, then you got unmuted. So thank you.
Oh, I'm really sorry. I'm making a lot of noise in my kitchen. I'm really sorry.
So now you have a kid who's really, showing a lot of distress. Then again, it narrows in on what are some of the primary concerns that you have. And so depending what you mark, it's going to narrow in on something that, may be a resource that's particularly matched to that need. So, if a youth already has legal involvement, then in addition to the services that are intended to be preventive of getting involved with the legal system, or that are designed to reduce recidivism, like multi-systemic therapy, multi-dimensional family, functional family therapy, you might be eligible, because your child is already on probation, you might be eligible for services that are funded by Court Support Services Division and can only be accessed. So then you would be guided, talk to your probation officer about LINK, which is a program that has clinic-based, evidence-based treatments to address various needs that often youth who are juvenile justice involved are struggling with. Or do you have a child who has emerging psychosis or the possibility of this? Then you would be connected to treatment programs specifically designed to assess and intervene at early level psychosis, problem sexual behavior. If none of those, then you are looking for intensive in-home services. This gives you office-based intensive IOP. And if you click on that, you'll see the IOP providers and whether they provide primary behavioral health, dual diagnosis, or primary substance use. The 4 bottom ones are in-home services, and it would bring you to a link to tell you more about what that is, what does it look like, where do you get it. So let me pause for a minute, because there's many ways that we can go about this. You can talk to me. I can show you this tool in action. You tell me a complicated clinical case and we'll go through it together, and you can see where you land and see what makes sense to you. I can show you the parent focus one. Let me do that for a moment, because the other thing, the child focus, you'll know, yes, there's, this is not the right, I'm really glad I'm doing this, because this is not the right version of the tool. The child focus will actually bring you, the first thing that you'll be brought to is they've loaded the wrong one. So it's wonderful that I've caught this today. It will bring you to, is the focus on the child, or is the focus on, oh no, here, I'll show you let me show you where that is. What it brings you, if you're in the parent, we're in the provider version. If you were in the parent version, it would say, do you need help accessing behavioral health services for your child, or do you need supports for yourself? Because we know that a parent coming to a website because they're up in arms about their child's status, they may need support for themselves. So if you have a child who has significant behavioral health concerns, or you have a child who you need to advocate with the school system to get their needs met, or you have a child with autism, we have one link that a parent can go down and identify resources and supports for the parent to navigate and to live with having a child with special needs and get peer recovery, peer support kinds of supports. That's in the parent version. But in this provider version, if the focus is on the parent, then the question is, what does the parent need? Coordination of care, access to resources that are going to stabilize the family, or do we need parent-based intervention? And for those of you who may not be as familiar with some of the really incredible programming we have in Connecticut, we have some programs that are really state-of-the-art, pulling together multiple evidence-based treatments to strengthen families while families stay together, but where families are referred because of the parents' concern. So for example, parental substance use. Is there DCF involvement? Yes. Then we're looking at what's the level of risk that you're concerned about. So this is using DCF language, but it's defining, there aren't conditions that place the child in serious, in harm's way, or there are some safety factors, but and there's a safety plan with DCF, but the children are in the home, or there are significant safety concerns and the children may be at risk of out-of-home removal. Depending what you click here, there are programs that work with families intensively, not only to address the parental substance use concerns, but also to make sure that we're addressing the impact of the substance use on the children in the family. So for example, with unsafe, are the children in the home, or there's a plan for unification? Yes. Then depending on the age of the child, if it's 0 to 5, child first and family-based recovery are two treatment programs with documented research supporting the effectiveness of addressing the parental substance use, improving the parent-child attachment and bonding, and enhancing safety. Very vulnerable population, and there's lots of focus on the safety. It's an intensity of service, multiple sessions per week, extensive safety planning. And in the 16 to 17-year-old range, we have multidimensional, we have multi-systemic therapy, building stronger families, which we actually at Wheeler, we were the first program to implement a pilot and then to do a random control group study working with the MST services and the Medical University of South Carolina. This program has had incredible impact in strengthening families, addressing parental substance use, and then healing the hurt that has happened in the family because of the abuse and neglect and because of the parent substance use. Traditional treatment was parents, the children are removed from the home, parents go to their substance use treatment, children may go to have their outpatient therapy, and then if the parent does what they need to do, then the family's reunified, but the impact isn't necessarily addressed along the way. And so this program is quite intensive in pulling together multiple evidence-based treatments, multi-systemic therapy for sort of this wraparound approach, reinforcement-based therapy for the substance use, trauma-focused CBT, prolonged exposure therapy for the parents, and clarification work. Or safe dimensional family MDFR, which is it's not a treatment, but it's a wraparound support model that provides in-home support to the family, addresses some of the parent-child concerns, but then helps the parent follow through with their substance use treatment in the more traditional route. So that's an example. We have other programs that are designed for other types of concerns that you might have, intimate partner violence. If that's a concern in the family, then you would be connected to programs that are funded by the Department of Children and Families. And then there's a new resource that's designed to help connect families to resources for domestic violence. And that's Safe Connect, and you would go to their website and it has a whole wealth of information. Pregnant new parent, the question is going to be, is there substance use as a concern? Depending what the answer to that is, because we have CAPTA regulation, so that would be an important place for somebody to go to see what services are available if the issue is parent substance use for the new parent. Know what are the needs, and there are some programs. And as the birth to 5, the early childhood programming expands our decision tree, we'll have more ways to hone in on which of these you might want to have involved. So let me pause and see if there are any questions, or if you want me to move on to the next part of my PowerPoint, or do you want to see this in action, reactions? I'd love to have a conversation about it.
Yeah, I'm wondering too how you all feel like this could be helpful. I think Elizabeth identified that if you're looking for a higher level of care, that certainly learning about some of these resources would be helpful. Any thoughts about that, or when you might turn to this tool?
Elizabeth, thank you so much. This is just so helpful. This is great, and I can see so many applications for this in my practice, and I know people that really need this. Sherry, just one really quick question. So many of the pediatricians seem not to know of these resources. So how are you educating the healthcare providers, the pediatricians, nurses on this?
So that's a beautiful question, and there's a couple of ways. So the first version of the tool, which was just the in-home models, one of the ways that we got a little bit of the word out there was through Access Mental Health. And so I did a presentation for pediatricians through and Access Mental Health, if you don't know, is a consultation service that's available statewide. Yale, Wheeler are two of the providers, and I want to say IOL or Hartford Hospital, the Hartford healthcare system, are providing the consultation to psychiatric consultation to pediatricians to help pediatricians manage behavioral health concerns that come in their office, particularly, consultation around medication management, but also it provides social work support so that there can be some other types of interventions and supports, and helping to connect families to resources. So pediatricians knowing about what these in-home evidence-based practice models are was a purpose of the training. So he's showing them the AIM tool because they could go there, but then also doing a little bit of a 101 about the alphabet soup. But that's another presentation that at some point, if you want, I'd be happy to do it, is what would you expect from each of these models if you had them? As clinicians, you might be more interested in that than just landing on the page that says, okay, for this need, MST for problem sexual behavior, you might want to know a little more what that would look like, because you could work with a family to understand that. So that's one way. And now with the new AIM tool, we're looking to do that. Access Mental Health would be one resource. Certainly the American Academy of Pediatrics, the Connecticut chapter, we could offer to do a training there. I'm going into school systems to do the training. I'm training the trainer. We're doing this training at network of care meetings, at regional advisory council meetings. We've presented it to the youth service bureaus. Anywhere that there's an interest, I'm working with the folks at Carillon that manage the Connecting to Care website and resources and grant funding to do community trainings, and I'm going to be presenting to probation officers, supervisors, presenting to DCF teams, et cetera. So pediatricians are somebody that we think could really benefit from getting this training, to know that the tool is there. And this training could happen in 20 minutes, just so you know the tool is there, because the tool does move really, really quickly, and it does really help narrow in on what you need. But that's a population we really want to get this training.
Yeah, I just had an email conversation with Steve Rogers, who's on the mental health he does a lot of work with you, but mental health subgroup of our AEP Connecticut chapter. And we had worked on this toolkit, Connecting to Care toolkit, that mentions the AIM tool. Anyway, we just talked about maybe doing a webinar for the AEP chapter. So maybe we can even coordinate that, where you could do specifically showing about the AIM tool. We could do the broad, so we can talk about that. But that it does make sense. The only other thing, Sherry, as you know, and Elizabeth knows too well too, I mean, the pediatricians are so overwhelmed. So knowing about the tool, but having somebody in their office who really is more expert on the tool and can, help them to navigate this would be great. Yeah. So it looks like Jessica too has a question.
Hi, this is, again, such a great resource. It's really wonderful to see all of this information presented. And just along the lines of what Sherry was talking about, I'm just curious if also, from a academic standpoint, because sometimes things can trickle down from that, you know, doing presentations at like Grand Rounds and UConn connections, or, you know, any number of venues where it's connected to something that's either state mandated knowledge or something that, again, you can really ensure that there might be a step up in how many people who could do something about the infrastructure would become aware of that. That was just one thought, because it's wonderful to see this work and energy go into all of the things that are there. Just that if people don't know about it, it's just so like, oh, so it's always the challenge.
Yeah, and that's one of one of the biggest challenges I feel these days is that we've got a lot of different statewide initiatives that are trying to address and improve the children's behavioral health system. And, you know, talk about the alphabet soup of treatment programs. It's the alphabet soup of legislative appointed bodies that are addressing children's behavioral health or overseeing children's behavioral health. We have some of these bodies have, one of them has 17, two of the Transforming Children's Behavioral Health, which is a new legislative appointed body, in the Connecticut Children's Behavioral Health Plan Implementation Advisory Board, have 17 overlapping members. And they're both addressing the children's behavioral health system. So this tool, making sure that all of us on those committees are aware that what we need to address are the crises that, you know, so one of the biggest disappointments of the tool in some ways is that right now our crisis in children's behavioral health is that there isn't adequate access, but not because we don't have some great programs, and we may need some other programs. And that part of that, the helpfulness of the tool is there are some areas where clearly we don't have all that we would like to have, or specialty services. But right now you could land on the perfectly researched matched intervention for your child's needs, and you wouldn't be able to get it because we have such shortages of behavioral health specialists in many of these programs. It's a phenomenal problem right now in our world. And so for this tool to be getting really a lot of attention and access as we've been expanding it may also result in a lot of frustration with the tool. But hopefully it leads to attention to, okay, but this is where I keep landing on, this is what I need, and yet I can't get it because, you know, there's limited capacity because we don't have enough providers, or there's limited capacity because we cut funding to that kind of programming. So that is where the tool and the efforts of these advisory bodies could come together. But, you know, the tool will allow us to know where people land, but it won't allow us to know, like I just landed on, you know, 20 different pages as one user, but I wasn't really, you know, so we don't, you know, that would be captured as data that somebody needed something that really nobody needs. I'm just showing it to you. So it's never going to be a precise estimation, but if we use it and we collect feedback, you know, that will be helpful to the system. But that's a very important point.
Extremely helpful to have the data collected to target where the needs are. Yeah.
And that's such a rub. Lisa has a question too, but Ro was asking for the website. Is it www.connectingtocare.org? I just wrote it, but I wanted to make sure that that's right.
Let me make sure too.
Okay.
So I can't see you because I'm just making sure I'm sending you the right one. It's Connecting to Care CT, no spaces, connectingtocarect.org.
Okay, I'll just put it in there. Yeah.
Okay. And again, it's Monday, it's going to look different than what it looks like now, the whole website.
So I have a quick question. When you're going through the tree, does it then further ask about your location and then where programs, like what catchment area is covered by, you know, certain programs? Because I feel like without this tool, I've tried to do it, but then sometimes the area that the client is in, there is no resource for where they live.
Yeah. So that is part of what we did was most of what is included would be things that are available in a lot of places, not necessarily everywhere. When you get to the landings, if it's a lot of the programs are funded by, at least partially, by some, state funding, whether it's the Office of Early Childhood or DCF. So then we have information sheets for that service type that have all of the providers. Now, the challenge was those weren't necessarily updated at the frequency we needed. So you could go to the DCF website and find out who were the providers for X intervention. And if that had changed, the sheet hadn't been updated. So we have on the Connecting to Care behind the scenes, management, we have all of the information sheets that are for services that are state funded. Those will be updated twice a year, connected to the AIM tool. If you go to, and so that says, but the problem is it says, like, it might say region 4, Hartford, Manchester. And if you don't know that region 4 is DCF lingo for, 16 towns that are, that makes it a little bit tricky. So I think that I have noticed that sometimes it lists the town and sometimes it doesn't. So as we get these information sheets even better and we get feedback, that's an example where we could put Manchester, Hartford, and then you put West Hartford, Bloomfield, Vernon, all the towns that might be served. In other places where it's a website you go to, so the one that comes to mind that I showed you today, the school-based health centers, you go to the school-based health center website, which presumably would be updated as new school-based health centers are. You go to the part of that website where you would type in what town you're in, and then you would see if there's a resource. So we've tried to make navigation of external systems a little bit easier to get to a page that will tell you if it's available in your neck of the woods. But even there, that's only as good as the website gives the, so the school-based health center is good because you can put in your child's school. And so then you'll know if they have it there. But other ones, you might have to figure out if this particular entity serves my town also. So.
Lisa.
It's a question that will probably get answered with time and use. But first of all, like, this is one of my dreams come true. So thank you for creating this. This must have just taken a massive amount of effort and coordination and work. And I can't even imagine what went into this. But I'm curious about being able to select multiple problem areas. I have a kiddo now with literally like trauma, adoption, history, gender and sexual identity issues, problem sexual behaviors, vaping. Like, those are the kids that I find myself like at a loss for. He's been kicked out of 4 schools over the past year. He was just kicked out of a residential. Like, those are the ones that are like, what do we do with these kids? So it would be great if we could have, some sort of access to, I don't know, just curious about the selecting multiple problems.
Yeah, so for what you've said, I would suggest you look into multidimensional family therapy, but that's not the point of your question. But if that's helpful, and if you want to, if I don't know who, Barbara, would you have Lisa's email? Or I'll put let's do it this way. I will put my email in the chat. You can email me. I will send you the information sheet about multidimensional family therapy, and I can explain to you why I think that. But that's beyond, like, that's just my mind, what it went to. The question you're asking is, of course, you can't do it with the tool, because when you get into the complexity like that, then the reality is you need and that's what we wanted to avoid too. The goal here is not that somebody goes and they come up, like, based on the questions we asked, like we thought about, do we want to assess the level of trauma? And then we might connect them to trauma treatment because we've assessed that, but we decided that we didn't want to do that, but we have trauma included in the description of outpatient things. But in this example that you gave, there is substance use concern, there's trauma that sounds like it's there's family disruption, there's a lot of different things, there's problem sexual behavior. You, as the provider guiding them, or if you were a DCF worker, you'd go to the regional resource group consultant in your office, and you could go through the tool and you could look at the program pages for each of those problems that you identified. And as you did that, you'd get more information. We didn't have time to stop and pause about the description of each program, but you'd say, oh, okay, so that program for problem sexual behavior will address this. They're going to go out 3 times a week. They work with the family. Maybe that would be the point to start, because that's where all the energy is. Or maybe you'd say, you know, the vaping's the tip of the iceberg, and we actually think there's a lot more substance use going on. Maybe you'd refer, you know, so you could look at it from that lens, because and what's beautiful about the tool, and this is where the interactive platform is, you can go back and forth really easily. The tool runs smoothly on your computer, on your phone. And so if you clicked on something, you say, oh yeah, they're not ready for this because we've got to address that other concern first. You can just click out of it and go back to the question and click down another one. So, you know, dual diagnosis would be another place to look. The reason I said multidimensional family, it depends again where the kid is living. We didn't talk, you know, again, I'm not giving you clinical consultation here, but I'm happy to, if you'd like to, you know, that will be the, you know, I'd be happy to do that, because I am knowledgeable about the intensive service system and trained in many of these models. Another question that there's another question, I think somebody else raising their hand, but another thing that somebody said about graduate school. So that, you know, I like the idea of how do we get knowledge of this tool in many different educational settings. And I heard it in the context of, you know, that like for medical students could get exposed to this, and you know, residents and interns and all of that. So yes, that's a good. And then the other thing I just wanted to share with you is that we have really tried to impact the higher education system to be aware of a lot of these incredible programs that we're doing in Connecticut weren't necessarily being trained in graduate schools. So we have all of this focus for the last 20 years on evidence-based treatment, and yet in 10 years ago, when we had over 600 positions for clinicians connected to evidence-based in-home treatment, none of the graduate schools were teaching it. And so now there is a course that was developed to really provide an introductory overview of these models. It was taught at the University of Hartford. One of the first, I developed the training first through federal funding, and now it's sustained through DCF funding to expose graduate students to evidence-based, a positive framework for evidence-based treatment more generally, and then what are these different models and what are some of the core competencies, and then what are each of the models, with the idea that we could improve the workforce knowledge about them, whether they go to do this kind of work or not, but also you know, you could pick that as a career opportunity. And I see that we're already at 2:00 and I didn't open it up to bigger questions, so
we are, but you presented a lot of very useful information, and in the chat, people are thanking you. I know a number of people had to drop off, but if anybody who's still on has a burning question, you can
yes, I can
send it
stay.
along, and we can.
Oh, I can stay. You may all have to go that are managing.
Okay.
I'm also looking for the chat to put my email. I can't find the chat.
Okay. All right. I can send it. I can send it out to the group too. So any last minute questions, as long as Elisabeth can stay, or no? I think this is it's really helpful. So that's great. And as you said, as private practitioners, you know, folks need to know, and it's hard to know about this entire system of care that we do have. And really the frustration is that we don't have enough service providers, but you're doing your best to figure that out as well. So any last questions, thoughts?
I have one question. Dr. Cannata, I'm Kelly Weber. I'm from the University of Hartford in the PsyD program, one of the faculty there. And I'm curious in the committees that you're participating on in terms of the pipeline issues, how that might be getting discussed. Is one of the kind of the main pipeline providers of students and trainees into the system. We've been challenged in our program past couple of years, even kind of recruiting faculty to our program, and worries about maintaining the program. We're kind of in a rebuilding state, but we're really looking for resources to even resource the program for pipelining psychologists in to our system. So I'm just wondering how that's getting talked about in terms of the provider shortage, if you have the chance to comment.
Yeah, you know, it's an interesting thing, because as a psychologist, I am challenged in answering this question, because I think that I have been focusing more on the master's level clinicians for many of the positions, not because that would be where, as a psychologist, of course we're being recorded here, but we're being recorded here for psychologists, right? But the reason why it's been, so like this in-home course is an example, in the beginning, really emphasizing having, University of Hartford was one of the first partners, and it was taught there because the evidence-based intensive treatment programs that we've been emphasizing in Connecticut across multiple systems. You want to get somebody who is ready to do that. So a new graduate would be perfect, but interns or externs, practicum students, are not good candidates because we'll do all the training for that year that they're a practicum student. Then they're going to go on a full-time internship somewhere else. And we will have done all that training, which is expensive, but we won't be able to keep them. So we've prioritized training master's level people. And I'm saying this again as a psychologist because I would love to be training psychologists, but we've done that because then you could do first of all, we have to get model permission to do internships, practicums, whatever, to do that in the in-home models, because sometimes the criteria for doing it requires that you already are ready. But we worked with model developers to say, well, it's a good idea to do internships because then they could continue, and then you've trained them and now they continue in the job. But for psychologists, that's not the case. The other thing is that that has not been necessarily the practice model, like for in-home treatment, that necessarily psychology has promoted as something that psychologists would do. And yet it's an incredible opportunity, especially for some of the more complex models with complex populations. Having psychologists be part of that is a phenomenal thing. So I would love to talk to you more about that in relation to those intensive treatment programs. I think in the area of integrated healthcare, that's like an easy one, because if you can connect to outpatient level care, and then there are opportunities that people could go on and do their full year internship training and then come back to Connecticut agencies, or do their internships in Connecticut or whatever. It's easier to do it if it's connected to outpatient level of care for psychologists, as opposed to being trained in a model that then you don't do for a year.
Mm-hmm. And, I think it also raises this important issue that you just addressed, that, certainly there are never going to be enough psychologists to fill behavioral health positions. Master's level, and that's why the APA is now going with master's level approval also for psychology. But Elisabeth and you all, many of you are great examples of psychologists kind of then taking a lead, not doing the direct services, but supervising the folks who do. But you first need to know what to do. You can't just be a supervisor. So figuring out the role for psychology and what's the niche that we fill, and educating the public as well, and not just the public, but legislators, etc. And Elisabeth, forgive me, I'm blocking on, I don't know if it's the Department of Human Services, some group in Connecticut recently put out an RFP, and it was to incentivize new psychiatrists and psychiatrists staying in Connecticut and bringing up the number of child and adolescent psychiatrists. That's great. And the other piece was incentivizing primary care, pediatric primary care. So this was all pediatric oriented, and I'll have to find the RFP for hiring, and it said a social worker in the pediatric office. So the pediatric office could receive money to hire a social worker. So I got in touch with them and said, gee, it just disappoints me, that, and I had another point I was making. And I didn't expect to hear back from anybody. I did hear back, and they said, well, that was what was in the regs, So somebody, and I'm sure it wasn't a purposeful, no, psychologists aren't, adept at this. It was just what people think of, social worker. So we put it in there instead of saying behavioral health provider, licensed behavioral health provider, which could have then been social worker, psychologist, marriage and family, whatever. Right. So it's also a lack of, I think, knowledge and understanding. And somehow we have to also educate, because there is so much legislation that is coming out in support of children's services. behavioral health services, but I don't know that everybody really understands what the unique value is of a psychologist and what the different roles a psychologist can play.
Yeah, it's a very big problem, and it is really limiting the scope of the workforce for children's behavioral health, but it's also missing out the opportunity of the expertise that we bring as psychologists. And like you said, social work, even if we just look at master's level, social work, marriage and family therapy, professional counselors, the regulation was just looking at social workers and why. And particularly we're working with children because, family therapists, but there's just a lack of understanding of what a marriage and family therapist. We saw that, Barbara, in our pediatric practice. Like having a psychologist, the fact that we're a doctor was actually helpful to getting in the door. Then when we wanted to have a marriage and family therapist, they were concerned, a licensed marriage and family therapist to be in the office, they were concerned that they only did marriage counseling. They didn't understand that they could do family therapy or that they could diagnose. Social workers, sometimes there's perception that they do more wraparound social service kind of things as opposed to mental health. And of course, that could be true. So just saying either any of these disciplines doesn't really tell you what the expertise is either. So psychologists, and then the other problem is that we're so phenomenally underfunded through third-party reimbursement and through grant funding that we can't afford to hire psychologists. We can't find master's level, but then if you add recognition financially for a doctoral level degree, we can't do it. So that's part of the challenge also. So we've been advocating for increasing, we haven't had Medicaid. We had a small Medicaid rate increase, but it hadn't been increased in like 20 years before that. That's, don't quote me on the number of years, but a lot of years. We had flat grant funding for like 14, 15 years for a lot of the home-based models. Home-based models, gas costs alone, they were reimbursing for mileage. Like right there, you can imagine that, our expenses go up every year connected to that alone. So that is part of the crisis right now. And so then when you talk about psychologists, but then we're losing that added, the training makes a difference. And I would like to get supervisors who have more the more experience that a psychologist would bring to supervisory roles for these programs would be fantastic. So we've got, it's like a multi-pronged approach, increasing salaries, increasing awareness of the different disciplines and what each of them brings.
Right. And then combined with that, and Kelly, you know better than any of us, I'm sure, but the cost of graduate education these days. And so wanting to recruit diverse, folks from diverse backgrounds, et cetera. I don't know if you've seen, Kelly, the workforce plan recommendations that CHDI, the Child Health and Development Institute, put out. You should take a look just to see, because not to say that their recommendations will be followed, but there are some very helpful recommendations there for both ends, both the training and and they at least talked about, for so many years it was kind of politically incorrect, I guess, we're, as behavioral health folks, we don't talk about fees, and we don't, we're doing this, and many of us do a lot of this work out of the goodness of our heart, that's for sure, but we should get paid as well. And so now at least front and center is that the reimbursement rates are absolutely insufficient. Both Medicaid and private, insurance rates are ridiculous. But
and then you have and Jessica, you're raising your hand so politely. I think we're all just shouting out. So you can put your hand down and shout out, and I'll be quiet for a minute. I'll make a comment after.
No, I think I wanted to mainly just share, it's connected with this, but it's also kind of more the theme of just getting the message out and having it be tied to potential legislation or getting it on legislative people's radar screens. I'm aware that there's going to be a inaugural Moving Beyond Implications conference that's going to be held at the Legislative Office Building on January 9th. From like 12 to 6. And I think it was targeted to the UConn InChip, which is a health and behavioral intervention research group. However, I think it's broader than that, and I certainly think it's very applicable to getting the message out about this tool to people who could really partner and use it in some way potentially. That I think just knowing it's out there, I can send you the flyer for it.
Yeah, thank you.
Again, it's through UConn. And it's actually Representative Jamie Foster, who is also a psychology researcher, I understand, who is helping to coordinate this. So there's already like a foothold of people trying to, get more information out there, and anything that tracks data is a gold mine.
Yeah, this is not tracking data.
Yeah, well, again, I don't want to, thank you for clarifying, but I also feel like it would be the necessary stepping stone to being able to document a need. And that's what probably the legislative community is going to want to see, is like some numbers about how many hits are you getting, how much are you finding certain programs are being asked for. I mean, I just don't think it would hurt. I don't.
Yeah, no, I agree with you. We talked a lot about, could we, the way it's set up, we're not going to have any particularly meaningful data, but if people who use the tool were inclined to say, especially providers, oh, we landed, this is what my client needed, but we couldn't get it. That, like having a place to provide that information would be very
over and over again. I think that's what EPA is finding is helpful to get people to understand the gravity of the issue. So I can put, there's not, I think they're looking for submissions or people to say that they have some interest in presenting something by December 15th. I don't know that it's really which legislators are going to be attending. We're going to focus on presentations from the following committees: Children's Education, Energy, Technology, Environment, Human Services, Judiciary, Public Health, Public Safety. So my hope is that you're already included in this. I never.
Yeah.
I'm sure.
If you send that along, that'd be great. Do you
That'd
have
be
Elizabeth's email address?
I'm sorry?
Do you have Elizabeth's email address? Or
No, I don't, but.
Yeah, I can't find the chat. Normally I can see it, but I'm not finding the chat. So if you can put it in.
Sure. I think it's under more on the bottom of your screen. If you go to more, and then you hopefully should see a chat function.
Yeah, I don't. When I do that, oh, here we go. Here it is. Okay. I saw it said show chat previews. I did. Okay, here, let me type it.
So my thing is whatever, it's a PDF. I don't know that I could put a PDF in this chat.
Well, I'm giving you my email.
Yeah, just send it to her.
Yeah, and I'm happy to send it to anybody. I don't think it's like top secret. None of this stuff is just, it's like nobody can get the message to the people who need to get the message. It's just too hard. Nobody's fault.
Well, thank you. Thanks.
Sure.
And thank you, Elizabeth. This, I think you stirred a lot of interest, and hopefully people will use it. So exciting. So Monday is the
launch of the new website and the expanded tool. So
excellent.
Yep.
Thank you.
And the other very cool thing, and then I'll let everybody go, is there's another Chestnut Health Systems, which does a lot for substance use treatment and evidence-based practice and screening and experts and all that. They are developing a Screen for Success platform, which is designed to screen for different behavioral health concerns, national tool. And they want to work with different sites. And so we've been talking to them about how we could use this, evidence-based research supported tool screening that you could connect people to identify needs, could then interplay with the assisted matching tool, because we don't want it to do diagnosis and all that, but also if people are doing screening and they say, oh, maybe my child does have a substance use treatment need, then they could be linked right to that part of the tool that says, and here where you can find treatment. So we're partnering to pilot the Screen for Success platform with the idea that maybe we'll have a chance to connect it.
Oh, cool. That's great.
Yeah.
Possibilities are endless, right?
Yeah.
Always, but that's wonderful. Well, thank you. We really, really appreciate the expertise, your sharing of your time. Really.
Thank you. Thank you all. I appreciate it.
And your passion.
Yes.
How much you care and
it comes through, right? Yes.
goodness. It's captivating. So thank you.
Thank you.
Thank you.
Have a good weekend, everybody.
Thank
And
you.
Jessica, if you can send me that.
Yep, I'm going to
that's
send it to you and to Barbara, and Barbara, you could send it to whoever you think would be helpful to have it. Yeah.
Okay,
But
thank you.
thanks again. Good to
Thanks.
see you.
Bye-bye.
Bye.
Bye, Barbara.
Bye, everybody.